It's my privilege to welcome you today on behalf of the Gastro Foundation and iEcho, supported by the Indian Echo for administration and logistics. As you know, these are Wednesday sessions, and this is an upper GI session. And I must admit, I now in my retirement do some medical legal work, and I can assure you that individuals are operating on some patients without due thought about their foregut problems. And every patient with heartburn may not necessarily require a fundoplication, and especially if they've had a previous fundoplication before. So I think hopefully we'll see and have some light shed by M Scriba, who is now a GI surgeon with a, shall we say, interest by default in manometry, but I believe he's thoroughly enjoying his new role, and he's going to simplify manometry for us and take us through a few cases, which I'm sure will enlighten us and give us a good handle. It's always good to get a clinician who's handling physiological tests because he knows when to use them and hopefully at least how they will help him manage the patient. So over to you, Matt.
Thank you very much, Prof. Let me just share my screen. All right, I hope you can all see that. So thank you very much for the introduction, and thank you for the invitation to present at this, which is actually an endoscopy session. And you might wonder why we're talking about manometry at an endoscopy session, but I think it's very relevant because anybody doing scopes is going to come across patients with foregut issues that can certainly benefit and arguably should have manometry. Now, esophageal manometry, unfortunately, is not widely available. We are very fortunate here at Groote to have recently acquired an up-to-date new machine. And since Dr. Sassaboort has retired, I've taken over from her almost by default. But hopefully I can give you all an approach to manometry. Certainly from our trainees, our surgical registrars, manometry is often very confusing to some of them, and people seem to not want to know much about it, but it is very important. And I think hopefully I can make it less confusing for anybody that finds it overwhelming. So what I'm going to do, I'm going to just give an introduction to manometry in general. So what it is and what do those pictures that we see, what do they actually mean? I'm going to present it as if maybe you've never seen it before. I'm then going to look at what we call the Chicago classification, which is the international consensus on how we should be interpreting manometry and how we should go about making diagnoses based on manometry, which is extremely important. And then I'm going to look at some 3 cases at the end to highlight what I've said before that. So what is high resolution manometry? So basically, in simple terms, it's a nasogastric tube that we put down, usually the left nostril, and it lies in the esophagus. And if you manage to get it down into the stomach, it's very important to get it to cross the Auger junction because it measures pressure. It measures pressure specifically of your lower esophageal sphincter and the body of the esophagus. We also do measure the upper esophageal sphincter, but that's often less important. So we're looking at the body of the esophagus and how it peristalses, and we're looking at what the lower esophageal sphincter does when we swallow. Now, it's important to follow a specific protocol, and this is actually outlined in the Chicago 4 classification. And we put the patient in different positions, but the basis of our analysis lies with 10 wet swallows. We do other things, but the first 10 wet swallows, so we get the patient to swallow 5 ml of water 10 times, and we analyze each one of those swallows individually, and we come up with basically an average of them. And you might have heard of something called a provocation maneuver. There's few of these that we do, and we basically, I'll go through those just now, where we try and get the patient to provoke certain things with him. In other words, for example, we do a swallow where we do a multiple rapid swallow to provoke peristalsis. So we want to augment their peristalsis. And we do a rapid drink challenge where we try to get their lower esophageal sphincter to relax optimally. So it's a provocation of the lower esophageal sphincter. Now, what's quite important, and I'm going to say this because often there's confusion about this, manometry is not the same as pH or impedance. So some people will say, oh, I will do a pH manometry on the patient. Now, that's not a thing in itself. So a manometry is a measurement of pressure pH is a completely different probe that we put in where we measure pH, the acid level in the esophagus. And impedance is a measurement of flow, of resistance to flow. And that's a test completely different again. But basically, pH and impedance are used to diagnose gastroesophageal reflux disease. Manometry does not diagnose gastroesophageal reflux disease, nor does it exclude it. But what it does is it looks at the functioning of the esophagus and excludes dysmotilities, which can so often mimic gastroesophageal reflux disease or GORD. And it's so important to exclude these before one goes ahead and does things, as Prof mentioned, like an anti-reflux operation. Okay, so this is what manometry used to look like in the old days, shall we say, not that long ago, but this is a sort of standard manometry where it gives you a graph. I wouldn't even know really how to interpret this correctly, and we've moved a long way since then, and we now get something based on a picture from a weather map. We call these contour plots, and they are based on pressure plots. The manometry, we call them Klaus plots. And basically, the color that you see here, the different colors represent different pressure. And this is now what high-resolution manometry looks like these days. So this is a manometry from a solid-state catheter that we used. And what you can see, this is a basic image of one swallow. On the side here is the legend for pressure. So the more red and purple it gets, the higher the pressure. On the x-axis here is time, okay? So time is, you can see here it says 1 minute 55, 2 minutes, 2 minutes 05. So this segment here is a 10-second segment. And what we can see here is a band of pressure at the top. Okay, and here you can see this is the esophagus on the side. So this is a band of pressure at the top, which represents the upper esophageal sphincter or cricopharyngeus. And there's a band of pressure at the bottom, and this is the lower esophageal sphincter. And here you can see a swallow has been initiated. How do we know that? We know that because the muscles above the cricopharyngeus, which are the pharyngeal constrictor muscles, are contracting. So there's increased pressure to push the bolus down. There's a nice break in pressure here of the cricopharyngeus, so that tells us this patient is initiating a swallow. And then a nice diagonal transition of a peristaltic wave, which is normal in this case and very good. And then what we see at the bottom here is the cricopharyngeus. There is a decrease in pressure here. Sorry, not cricopharyngeus, the lower esophageal sphincter. There's a decrease in pressure here, and that represents opening of the lower esophageal sphincter, which of course has to happen when we swallow. What's very nicely represented here is this little break in pressure here, and that's a visual representation of the change from the skeletal muscle in the upper third and the smooth muscle in the 2/3 below that. So the transition between skeletal and smooth muscle here. So that's visually represented, and we call this the transition zone. So that's normal as well. Okay, so we've got time at the bottom, upper esophageal sphincter, and the lower esophageal sphincter below that. I hope that's quite clear. And what we do with these 10 wet swallows, we then analyze what the peristalsis is doing and what is happening to the lower esophageal sphincter, as I mentioned. That's the most important thing. Now you'll see all these other bits of changes in pressure that occur behind it. Those are artifactual. Remember, we're measuring pressure inside the esophagus, but it is influenced by pressure outside, most notably in the thoracic cavity. So the heart beating against the esophagus and the changes in inspiratory and expiratory pressure are represented here. So we essentially ignore these, but this is what we're seeing here. This is not peristalsis. So this, what you see here, is not peristaltic activity at all. It's artifactual. Okay, now when we look at the picture, we have to also understand certain metrics that we measure. So the machine automatically measures them, although we have to put the markers in the correct place. But there's basically 3 metrics that we have to measure, and this sometimes confuses people. So hopefully I can make it a bit more simple. The first and most important metric is always this box, this 10-second box down here, which is measured from the time the swallow begins. So there's a vertical line drawn here for the next 10 seconds. And what is that? This is called the integrated relaxation pressure, or IRP. And what this is basically looking at how much maximally your lower esophageal sphincter relaxes when you swallow. And what the software does in this 10-second of pressure, it measures the 4 seconds of lowest pressure, and we represent that. And when we're talking about an IRP measurement overall, we will take an average, a median of 10 swallows, and that will be the IRP. And that's how we go about making diagnoses such as achalasia. So this is very, very important. And I'll show you just now with Chicago 4, with the algorithm we follow, this is the first thing we look at, and it immediately moves the patient into one of two directions. So we measure the IRP, or integrated relaxation pressure, first. Then we look at this box above here, and this is measuring the peristaltic activity of the esophagus above the lower esophageal sphincter. And this we call the distal contractile integral, or DCI. And this is simply a measure of vigor. We are looking at how strong this contraction is. Is it normal? Is it too strong? Is it weak? Or is it failed? Those are basically the four options we come up with the DCI. And it's a box here. You don't need to worry about the units we use, but it's basically pressure over a surface area. And then the last thing we look at is a measurement of time we call the distal latency. And what this means is the amount of time it takes from the beginning of the swallow, this marker we put here, to where the peristaltic wave reaches the point where it starts slowing down, where it starts decelerating. We call this the deceleration point. And what normally happens is when the peristaltic wave reaches what we call the ampulla of the esophagus down here, you get a slowdown in peristalsis. And this marker here, this measurement from the beginning of the swallow to this point, we call the distal latency. And we are only interested if this is too short. If it's less than 4.5 seconds, then it meets the criteria for spasm. Okay, so the term spasm in the esophagus is not about the muscles contracting too strongly or in a funny way. It actually means that the peristaltic wave is progressing too quickly and usually does not help with bolus propagation. That's why these patients get chest pain, etc. And a bit more about that when we talk about the cases later. But this is the third metric we measure. So here they are, IRP, DCI, and the distal latency. And it's important to know what the normal ranges are when we look at these results. Some of you who order manometry for the patients might not get a thorough report where the manometrist has actually interpreted the findings, but they might just actually give you the actual results with the ranges. So then you have to actually know what you're looking at. Now, the IRP, unfortunately, doesn't have a standard reference range across the board. It depends on quite a lot of factors, and you need to know these things when you are sending the patient. So you need to know what system is being used. Okay, so there's different manometry systems worldwide. Laborie is the one we use. Medtronic is the most commonly used ones in places like the United States. There are others, and they each have their own reference range for IRP. We need to know whether the catheter used is a water perfused, which is a slightly more older catheters used, versus the newer solid state catheters, and you can see them visualized here. The difference between the two is in a water perfused catheter, you have one pipe, but in the pipe are usually 24 individual smaller pipes that all drain to one of these pipes here. And what the machine does is it pumps water into each individual pipe, and you get a column of water all the way down and coming out the hole here. And you then have the pressure of the esophagus transduced through this column of water all the way back into the machine. Okay, and you get 24 different readings. And that is very different to what happens with the solid state catheter. This is less accurate, but is also reliable. And many of the machines we have in South Africa and throughout the world still use a water perfused system. The new solid state catheter doesn't have any water going through it. And you can see these little black dots. Each one of these little black dots is a pressure measurement device. It's circumferential. And basically, this is much more accurate, a little bit more tricky to get down, but is more accurate and is what we use on a daily basis here most commonly. But it's important to know that between the water perfused and solid state, that the IRP also differs in terms of what's normal. Then the patient position also makes a difference. If you have the patient lying down, and if you sit them up, once you sit them up, the IRP drops down. It goes lower. So locally, when for the most part, what we look at, what I will look at, I use a Laborie system. I've got a solid state catheter that I usually use, and the patient starts in the supine position. So for all of those, 22 is my magic number for the IRP. So if it's above this, then it's raised. Then we are talking about an urge junction outflow issue, which could be achalasia or not. We'll talk about that just now. DCI is, for some reason, I'm not quite sure, but it's the same across the board. It doesn't matter the machine, the position, the catheter. We use the same reference range. This is a bit easier to remember. So we use normal between 450 and 8,000. Weak is less than 450, but more than 100. And once we reach any DCI of less than 100, we call it a failed contraction. And more than 8,000 is called hypercontractile. And then lastly, as I mentioned, the distal latency should be above 4.5 seconds. That's normal. If it's less than 4.5 seconds, we call that potentially spasm. The other thing that's quite useful on a manometry, and I hope it's clearly visualized here, this is in a resting position. So the patient is asked to not swallow for about 30 seconds, and we get these two bands of pressure. This is the upper esophageal sphincter. This is the lower esophageal sphincter here, but there's two bands of pressure, which are outlined here. And why that is that this patient has a hiatus hernia. So the bottom pressure here is the pressure of the crura of the diaphragm imposing itself on the esophagus, while this pressure up here is actually the true lower esophageal sphincter. And in a hiatus hernia, these separate, and you can see, and you can actually measure this distance. And the point here is that manometry is actually quite accurate at diagnosing hiatus hernias, especially the sliding ones, the smaller one. If it's a really big paraesophageal hernia, it's sometimes not as accurate. But this is quite important, and we can sometimes quite usefully infer whether or not the patient has a hernia, despite what's been said on the scope. Now, just briefly on what the provocation maneuvers are that I mentioned earlier, there's two main ones we use. We use the multiple rapid swallow and a rapid drink challenge. Okay, and the multiple rapid swallow looks for peristaltic reserve, and it allows us to work out something called the dysphagia score, where we simply take a ratio of this peristaltic augmented peristalsis from the multiple rapid swallow, and we divide it by the vigor of the swallows for the 10 other swallows, and it should be greater than 1. In other words, when you augment the peristalsis, it should be higher and stronger than what it is with the other swallows. That's simply all it means. And it is a marker, although not fully, hasn't been fully validated, but we do use it, and it helps us to predict whether the patient will have dysphagia, or it predicts a higher risk of dysphagia after anti-reflux surgery if it's less than 1. And then the rapid drink challenge looks at lower esophageal sphincter relaxation. So let me show you what this looks like. So here's a multiple rapid swallow. What we do is we give the patient 2 mils of water 5 times, very quickly, one after the other. So we make them swallow, 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 swallow. And every time you make a patient swallow rapidly after each other, it stops any peristalsis going. It interferes with it. And basically, once you've made them swallow 5 times in a row, you then allow them to have a clearance contraction. And this should be bigger and stronger than what it is normally. And that's all we're trying to see with a multiple rapid swallow. With a rapid drink challenge, which looks like this, we actually just get the patient to drink 200 ml of water through a straw at their own pace. And so you can see they drink, 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 drink. And what's supposed to happen is that your lower esophageal sphincter, which you can see here, is supposed to relax completely, which is what we see here. You can see the pressure is dropping completely. Usually you shouldn't see any contractions in between here, okay, because they've been stopped, okay? And then you have some sort of a clearance contraction at the end. But again, with the rapid drink challenge, we're not so much interested in this. We're interested in the lower esophageal sphincter relaxation. Okay, so that's basically what manometry is and how we look at it. Now I'm going to just spend a few minutes looking at how we actually go about interpreting this based on this, the Chicago 4 classification, which was updated in 2020 to the 4th version. And this is what is used worldwide to this day. And the most important thing, so it's an entire paper, you can read it. I think it's very important for any exam candidates to definitely know about Chicago. But basically we land up with, this is the most important table or figure from the entire paper, and it's the flow diagram we use to make these diagnoses. And it looks very busy, but let me try and see if I can simplify it for you. So the first thing we do is we look at, remember I spoke about the IRP, we look at the IRP first. So is that high or not? In other words, is there lower esophageal sphincter outflow obstruction or not? And as soon as we say yes, we move down this pathway to the left. If we say no, we move to this pathway to the right. And if we move to the left here, we either are dealing with an achalasia, and so we look at the IRP plus failed peristalsis, and in achalasia, there must always be 100% failed peristalsis. And based on what that peristalsis looks like, we then divide it into type 1, 2, and 3. I'm not going to spend a lot of time on achalasia today per se. Or if it's not achalasia, in other words, the IRP is raised, but there is peristalsis, we are dealing with an EGJ or OG junction outflow obstruction. Now, this has a huge variety of different causes in it. Some of these patients may well be what we call achalasia in evolution, but we get a whole range of other problems that give an outflow obstruction, strictures, pseudoachalasia, etc., etc. On the other side, on the other flip side of the coin, are the cases where the IOP is normal. So in other words, it's relaxing. It's not achalasia. It's not an outflow obstruction. But then we look at whether there's a peristaltic issue. Okay, and really with Chicago 4, they've made it a bit more simple than previously. We are left with only 4 major peristaltic issues that we can diagnose the patient with. The first one is called absent contractility, and what this means is that 100% of all the swallows have got failed peristalsis. So not even one swallow has got a weak peristaltic wave. It must be failed on all of them. Then we call it absent contractility. If that's not the case, the next thing we go, and you start at the top and you work your way down. The next thing is distal esophageal spasm. It used to be called diffuse esophageal spasm. We now call it distal esophageal spasm. And what this is where we have at least 2 of the 10 wet swallows, in other words, 20% or more, should have spasm. And remember what spasm means? It means that there's a distal latency of less than 4.5 seconds. It means the peristalsis is occurring too early. If we don't have that, the next thing to consider is your hypercontractile esophagus. Okay, the old term used to be nutcracker esophagus. This has fallen out of favor completely. That's based on the old standard manometry. We now talk about the term hypercontractile esophagus. Another term is jackhammer esophagus. It gets even more confusing because actually jackhammer esophagus is now a specific type of hypercontractile esophagus that we recognize. So not all hypercontractile esophaguses are jackhammers. So I think one has to be careful to call it a jackhammer. I think you speak, especially for exams, stick to the generic term hypercontractile esophagus. And then the last one, and for hypercontractile esophagus, you need 2 of the 10 swallows to have a DCI of more than 8,000 to be hypercontractile to give the patient that diagnosis. And then the last thing is an ineffective esophageal motility, or IEM, which is the most common peristaltic disorder we see. And that simply means that there's weak peristalsis. If you don't have any 4 of these and the RP is normal, then we call it a normal manometry. Then the esophagus function is normal. Okay, so in summary, it's either achalasia, outflow obstruction, a peristaltic issue, or normal. And that's basically what we use the Chicago for. Okay, so I hope that's all clear, and I invite anybody, if you have any questions, to put it in the chat box, and we'll go through that at the end. But what I'm going to do is try and put some of that into practice by giving you just 3 cases, and also show you how we use manometry and why manometry is actually invaluable in some patients. So here we've got a young female, she's 35 years old, who was going towards needing or thinking that she really needs an anti-reflux operation, a Nissen's fundoplication. She had very severe symptoms, heartburn, chest pain for 2 years. And on further questioning, she also has some loss of weight, which is always something to ask about. And she had dysphagia, although she didn't consider it a major component of her symptomatology. I think anybody who's being worked up for reflux who has dysphagia should be considered for manometry. Okay. She's otherwise well, no comorbidities. And as a surgeon, that's a good thing. We now think, well, we've got a young, fit patient. This is the perfect patient to have an operation. And when the scope was done, the report showed some esophagitis. This wasn't specified. Unfortunately, don't have pictures of the report. And there was probably a hiatus hernia present. So now it seems quite clear. We've got a patient who's got heartburn, who's got esophagitis, maybe, and a hiatus hernia. So this sounds classic for GORD. Is this a confirmed GORD? Should she have an anti-reflux operation? Well, fortunately, the surgeon didn't just sharpen his knife and sent the patient for a swallow first. And I do think a barium swallow is an extremely useful investigation to do. If you don't have manometry, please at least do a swallow. And I'm going to run this again, but basically what the swallow shows, let's just run it again. There it goes. So the esophagus does look abnormal. It's slightly dilated. Certainly does drain, so there's not major holdup, maybe a bit slower. And there's definitely no classic bird's beak or rat tailing, although on this image you might now say, well, maybe that is a rat tail. Okay, but this is not screaming achalasia per se, but there's definitely a problem here. Unfortunately, this patient was sent for a manometry, and what we found on manometry was this. So just to remind you again, this is the lower esophageal sphincter, this is the upper esophageal sphincter, and what we have here, this box is the IRP, and her IRP was 22. And this was done a few years ago where we used a water perfused catheter. So for that, the reference range is not 22, but 18. So this was high. And on the median of 10 wet swallows, the IRP was raised. So we are now dealing with either an achalasia or an EGJ outflow obstruction, okay? Both of which are problematic if you're thinking of doing anti-reflux surgery, because if you go and make that sphincter tighter, you just make the patient worse. It's the opposite of what you should be doing. So now how do we decide if it's achalasia or not? Well, we look at the peristalsis above it, and I'm only showing you one swallow. Remember, we always look at least 10, and this is classic, and they all look similar to this. So all of them don't have proper peristalsis. This is not a true peristaltic wave at all. And what this is aperistalsis with panesophageal pressurization. So what you can see as the swallow begins, there's immediate pressurization of the whole esophagus in one vertical column. And there's a bit of shortening here, which you can see here. And this is very classic of type 2 achalasia. Okay, panesophageal pressurization and shortening. And remember, the reason why we have this with shortening is that in type 2 achalasia, which we consider an earlier form of achalasia, and that's why the swallow in this patient didn't scream of achalasia, is because they still have some residual function of their longitudinal muscles. The circular muscles don't work anymore, or are denervated and don't get the signal to work anymore, but the longitudinal muscles still have some excitatory fibers that work. And so what happens here is that they contract and the whole esophagus pressurizes at the same time, and you get shortening. Okay, so fortunately, this patient did not have a Nissen's fundoplication, but rather a Heller's myotomy. Okay, so that's a nice quick case to start with. Now I'm going to go a little bit more, slightly more complex case. This is a patient that came to me in the last 2 months, all the way from Namibia. She's 41 years old. She's very well. She's a tour operator. And in 2018, she had a Nissen fundoplication performed. Now, at the time, pre-operatively, she had significant symptoms of volume reflux with heartburn. She had confirmed LAB esophagitis, and I'm not focusing on that so much today, but remember the Leon classification for the trainees on the group. The Leon classification has now been updated to its second version last year, and we now consider LAB esophagitis to be pathological, or to be confirmatory proof of pathological GORD, and she had Barrett's. So she's got enough reason to say, yes, she's got pathological reflux. And I don't know if a barium swallow was done. I don't have access to that, but she had a Nissen's done, and she had some improvement, but then 5 years later had recurrent severe volume reflux and had a redo Nissen's done. Now, since then, she's had terrible heartburn and acid regurgitation. Now, again, this sounds like, well, what's happening here? Is this now, does she need a third Nissen's and things must be made tighter again? But she does say there is dysphagia. And again, that's always something we need to ask the patient about. Dysphagia is very, very important. She didn't describe it as a particularly prominent symptom. And remember, we do something called an Eckhart score. So this is a score specifically for achalasia. But the recommendation is now to do this for any patient with dysphagia. And I certainly do it for all my patients that come in with dysphagia. And it's a score that looks at 4 things: dysphagia, regurg, chest pain, and loss of weight. And you give each of these a score out of 0 to 3, and the total is therefore 12, and she only scored 5, which isn't particularly high. The other thing is that she had improvement on her daily PPI. In fact, she says when she stops it, she really can't function. She's got no comorbidities, does smoke a little bit, but no other medication use, specifically opioids. And remember, opioids are so important to ask about because they make the esophagus do all sorts of weird things, and certainly in themselves can cause dysphagia. And on the latest gastroscopy, she had a small slipped Nissen, so there was a slip wrap and ongoing esophagitis. So with a symptomatology, response to PPI, and esophagitis, we might be thinking, well, we've confirmed that there's ongoing pathological reflux, and we should be going ahead and redoing the Nissen for the 3rd time. Again, a barium swallow is such a useful investigation. So I've got some still images here. And what you will notice on this image, very nicely shown, is that the esophagus is definitely dilated. So how do we know it's dilated objectively? So we compare the diameter of the esophagus to the diameter of the vertebral body. Okay, and here it's shown very nicely. So a usual vertebral body in an average adult is around 4 centimeters. And the esophagus should really be never be more than 2 centimeters. It should never be more than 50% of that. And in this case, we can see that it's not just more than that, it's actually greater than the vertebral body. So this is significant dilatation. You can all see here that there is certainly a small recurrence, not a very big one, but looks like a recurrence. And this is another still, and I think I have one video to show. Here we go. And I think what you can all see here is that there's an air fluid level or an air contrast level. And so there's hold up here. There's lack of drainage. Okay, so that is concerning. So now, are we really dealing with reflux, or are we actually dealing with a problem of drainage? And what's important with this case is that lack of proper drainage of the esophagus can mimic reflux in so many ways. And that's why manometry is so important. So fortunately, this patient came for a manometry, and this is what we found. Again, so let me remind you, here's the upper esophageal sphincter, lower esophageal sphincter here. And you can see every time she breathes, there's variation. So this is at the level of the crura here. And you can see there's absolutely zero peristalsis here. So she had complete absent peristalsis. So that was her manometric diagnosis. But before we can say that this is true absent peristalsis, we have to look at the IRP first. And her IRP here was 22. Okay, which in this was the solid state catheter with her supine. So this is at the upper limit of normal. Now, remember, it's not just one swallow. So here's the 10 wet swallows, a summary of it. And here the IRP was 19. So that's certainly at the upper limit of normal. It doesn't meet the criteria to call it an outflow obstruction. What is important to say is that say it was high, say it was 25 and there's aperistalsis. The question is, well, is this now an achalasia that's been wrapped? Or is this actually post-surgical changes? So the problem is we can never call it an achalasia, and it's usually almost always a consequence of the surgery. And when you make things too tight, which is probably the problem here, you land up with an almost burnout of the esophagus. Okay, so that might be a consequence of that. Or she may have had aperistalsis to begin with without achalasia, and then the wrap was done. So we don't know, something we cannot tell in hindsight. Here we've proceeded to then sit her up, and then we do 5 wet swallows upright. And in this position, the IRP was 18. So when I sit the patient up, the IRP drops and the normal reference range is 15. So this is above that. So this is raised. So here in a different position, we are dealing with a potential OGJ outflow obstruction. And when you did the multiple rapid swallow, you can see here the idea is to look for augmentation of peristalsis and peristaltic reserve. And in this case, there was 0. So there's 0 peristaltic reserve. So this patient has no peristalsis at all. And certainly, I think a redo Nissens and making things tighter again is the exact opposite of what this patient needs. And the IRP here also was slightly up. Okay, and then the last thing we do is the rapid drink challenge. And what you can see in the rapid drink challenge, if you look at this bar down here, is that over time, it should be relaxing completely. And actually, the opposite is happening. And it starts pressurizing as the patient drinks more and more. So there's definitely an issue at the lower esophageal sphincter, and above it is no peristalsis. So we then went on to do a 24-hour pH test. Okay, one may argue that you maybe don't need to do this in this patient. I think that's true. We did do it because it was requested and we thought it was a good idea. And in this case, was really, really interesting. So the talk today is not about pH testing. That's a different thing, but just I'm going to take an aside quickly here and just look at this because it was interesting in this case. So remember, a pH test is a catheter that we put in after the manometry. The patient goes home with it for 24 hours. It sits 5 centimeters above the lower esophageal sphincter, and it just measures pH. And what we do during that 24 hours, we measure how often the pH at that level drops below 4. That's considered a true reflux episode. And at the same time, we also ask the patient to push a button every time they have their symptom. And then we see if there's symptom correlation. So what we found in this patient is that the acid exposure time, which is the most important metric we look at, and we now say that if it's more than 6%, it's basically confirmatory of pathological GORD.
Hers was 24%, which is very, very high. Okay, so does she actually have reflux? Now things become a bit confusing. But she only had 20 reflux episodes, and we consider anything less than 40 to be normal. More than 80 is abnormal. And when we did a symptom analysis, we look at a symptom index and a symptom association probability. You don't need to know too much of the details here, but basically these were both negative. So her symptoms, and she only had 6 episodes of heartburn when she pushed the button. So it wasn't that symptomatic during the 24 hours. So now it's a little bit incongruous here. We've got a very long acid exposure time, but low reflux episodes, numbers, and no symptom correlation. So what is going on here? So then it's important to actually look at this. This is what the pH study looks like. This is a 24-hour representation. The pink lines here are when she eats or drinks. And during that time, we actually exclude. So we exclude these reflux episodes when they eat or drink. So we take these out. But the most striking thing, ignore everything else, is just look at this episode here. So this is a true reflux episode that occurred. It's true reflux because it drops very rapidly, and then it slowly increases in these incremental stepwise fashions, because that's what's happening there, is the patient is swallowing saliva and making mucus in the esophagus, and that's trying to neutralize the acid that's in the esophagus. But what's most striking here is that this single reflux episode lasted for almost 3 hours. And it occurred, this is midnight here, so it occurred just before midnight while she was asleep. So what happened here is that she had some of the acid from her stomach go up into the esophagus, or she drank something before bedtime that was acidic, and some of the things we drink like orange juice are quite acidic, and it basically could not clear, and it lay in the esophagus for 3 hours, causing acidity and what we would think is reflux, but it's not. It's actually just a lack of drainage. Okay, so that really gives us the answer here. So this case is a case of a patient not draining the esophagus properly. So what we told her to do was to start medically and take her PPI twice a day, so she has coverage at night. Quite useful to add something like Gaviscon or sucralfate if you have it available to take just before bedtime, so it coats everything. But ultimately what she needed was to address that low esophageal sphincter. Some people might question, should you do a balloon? I must say, I'm not a big fan of a balloon. And what we actually suggested is that she have a repeat surgery, but not to redo the Nissens, but the opposite, to open up, loosen the crural apposition. And remember, when we do anti-reflux surgery, we don't just do a wrap. We always have to fix the hiatus, which is the crura. So to open that up and to convert the wrap into the least dysphagic producing wrap, which is an anterior partial fundoplication. One can even make an argument for an angle of His augmentation. But, this case is very tricky because she probably did have true reflux initially. So you don't want to revert back to a state where she's refluxing constantly. But her main problem at the moment is dysphagia. But I think the case shows quite nicely how important manometry is in a case like this. And then the last case is just one of interest, where we found something that we don't often see. This is a patient in his 50s who came in with vomiting and dysphagia. Now, there was a bit of a red herring initially where he was diagnosed with an ulcer on scope in his stomach, and the biopsy of that initially was provisionally shown to be a cancer, but subsequently was shown to be benign. But we were referred the patients as the surgeons, saying there's a cancer in the stomach and the patient's vomiting. We thought, well, this is a malignant gastric outlet obstruction. Nasojejunal tube was placed. The patient was admitted. He also had diarrhea, which was attributed to a Shigella culture in his stool, and that resolved with appropriate treatment. But then we actually took a more thorough history, and we then realized the ulcer is actually just a red herring. It's just an ulcer in the stomach. It wasn't actually causing anything. And actually what he has is dysphagia and regurgitation. So the vomiting was actually regurgitation and not true vomiting. And I think one needs to separate those two, because vomiting is an active event where you retch. Regurgitation is passive, and the things that you have just come back up. And they usually imply that there's a problem in the esophagus. It's not a gastric problem. So he had this dysphagia and severe chest pain actually for a year's duration already, and had been living with us at home, hadn't really presented, and had an ECOT score of 12, so maximum. He was dysphagic with every meal, chest pain with every meal, regurgitating every time he ate, and because of this had lost almost 20 kilograms already. He had some hypertension, depression, was on an antidepressant, non-smoker. Bit of a confusing story here because he had aniston some 30 years ago, but perhaps not that contributory in this case. And multiple back operations, including a nerve stimulator. I mentioned this because it obscures the barium swallow I'm going to show you now. And on the endoscopy, which we did here, the esophagus was actually reported as normal. OG junction quite reasonably easily negotiated, and we had that ulcer in the stomach. Now, the barium swallow, which follows here, you can see, looks very abnormal. Okay, so I'm going to show you the lateral now. This is the nerve stimulator, which is a bit confusing, but let me run the swallow again. And what you can see is distally is that the esophagus is doing something we call beading. So you can call it a corkscrew if it looks like it's twisting, but this is classic beading, and it's more evident on the lateral here. Okay, there's the lateral. It can look like something like this. There's beading as well. This is from another patient. Or what we call here, you can see this is the classic corkscrew esophagus. You can imagine it twisting like a pig's tail. Okay, and this is suggestive but not confirmatory of esophageal spasm, distal esophageal spasm. And what we found on the swallows, I'm not going to show you all 10, but basically 3 of them looked like this, 3 of the 10. So you've got a very high pressure contraction here. And if you look at it, the DCI is 14,000. I remember more than 8,000 meets the criteria for a hypercontractile contraction. Okay, so you had this in at least 2. So we would say, well, is this now a hypercontractile esophagus? Jackhammer, but this doesn't meet the criteria for jackhammer. But more importantly, was that the distal latency was 4.3, less than 4.5. So this trumps the DCI. Okay, and he had most of his swallows had a distal latency of less than 4.5. So this met the criteria for a distal esophageal spasm, which is a very strange disorder because we don't really know the pathophysiology of it, and the treatment is particularly difficult. This is an overview of the 5 upright swallows, and what you can see is that the average distal latency was 4.3, so it reaches the criteria, and every one of these swallows was too early, and you can see how vertical the swallows look, and they are also quite hypercontractile. Okay, but this diagnosis is a distal esophageal spasm, and the management is quite tricky. So the suggested medical management and what one should start with is always calcium channel blockers and nitrates. We know that in especially the hypercontractile esophagus, which is a different diagnosis, but seems to be quite similar in that it's got quite an unusual clinical course in that it often resolves spontaneously and then recurs in some patients. So doing anything definitively is one should be guarded against doing that because waiting often the patient to resolve the symptoms. Now, in this patient, what's important is that he was really, really symptomatic. And the first time he came for his manometry, he actually needed to be admitted because he was so dehydrated and hemodynamically unstable. He just becomes so dehydrated. So he first had to be resuscitated. Then we could do the manometry. So we opted to do something. We actually gave him Botox. And he's improved from that at the moment. And we're waiting for his next 6-month review. A myotomy is described, specifically a POEM, a per-oral endoscopic myotomy, but I think doing something definitive really has to be done on an individualized basis. One has to wait until one decides to do that in this patient. Just lastly, this is just to show you what a hypercontractile esophagus would look like. So you can see the same purple pattern. The DCI here is 23,000. But the distal latency is 6.6 seconds, so it's much longer. So this is not a spasm. And this, if you have 2 or more swallows that look like this of the 10, we would call this a hypercontractile esophagus. Okay, so that's all I have for you today. In conclusion, I think hopefully I've shown you that manometry is actually vital in dysmotilities in general, but specifically in many patients that may have a dysmotility, and you don't know it until you've done the manometry, because this is the gold standard for diagnosing this. Unfortunately, it is not readily available, but I do think if you're in a place that doesn't have manometry, but you have access to a referral center that does, please make use of them. And unfortunately, as surgeons and as gastroenterologists, we do need to have an understanding of manometry, because we're not always in a position where the person doing the manometry is a clinician. It might be a technician, and you will get a printout of the manometry report, almost like what you get with an ECG. And then it really is up to you as the treating clinician to have an understanding of what that means so that you can appropriately treat your patient. Thank you. Okay, I'm going to just proceed with answering some questions in the chat, if that's okay.
Carry on. Good to.
Okay, great. So let me just have a look. There's a couple of things here. So Karan Gandhi has asked us all the way from Kenya, I think. So he's asked if we have a patient with reflux, the first patient, would you consider a wrap when you do the helismatomy? Yes. So yeah, I didn't cover that specifically, but when we do a helismatomy, we almost always do a wrap. We do an anterior partial fundoplication. We don't try and fix the hiatus because that's not the problem. So we don't put crural stitches in, but we almost always do an anti-reflux procedure, an anterior fundoplication. That has the least risk of making the dysphagia worse, but yes, there is always the risk of reflux, and we know that that's a problem because in patients that have a POEM, a per-oral endoscopic myotomy, we don't do a wrap because you're doing it endoscopically, and their risk of reflux is very high. Up to 40% of these patients have significant reflux. So that is one of the drawbacks of a POEM. I hope that's answered that question.
Indeed. Can I ask one of you? One of the things I think that's quite difficult when you see the manometry is to pay attention to the temporal scale, which you adjust when you look at it and you do these swallows, because it does make the actual visual impression very much different depending on how you've adjusted the scale. So I think you should, the individuals who are looking at it and looking at printouts or reports should be very wary of the scale, because it does, I understand the calculations are made, but the initial visual imprint, even when you showed just now, when you showed the last patient, as you do the frequent swallows, the scale changes. Obviously, it has to change so you can see them. And it does make us, for the uninformed, it doesn't have the same visual impression as when you see a single swallow. So just watch the scale, and obviously you mess around with it to obviously make the calculations and for the machine to do it.
Yes. Yeah, no, absolutely. And when I show you that of what it looks like, a summary of the 10 swallows or 5 swallows, the machine does that automatically. And yeah, you're not using that picture specifically to look at the visual imprint, but it does give you, the software does all the average calculations on that. So that's the most important thing. You look at the numbers. If you're wanting to look at the pattern, you must look at the individual swallows, which are on a scale you can't adjust. So absolutely agree. I think if you're looking for the visual representation, the pattern recognition, which is part of manometry, you need to do that on the individual swallows. And that's most important, actually, which I've learned quite the hard way, is that while you're doing the manometry, it's running live in front of you. The pictures are live, they're running. And sometimes you think you're already making a diagnosis based on what you see. But then once you actually go and analyze it properly, it can look quite different. So the analysis is very important, must be done on the still images of the single swallows. Absolutely agree.
And
okay,
again, sort of, obviously you gave us a flavor that manometry is important, and you touched on the Leon classification, all right? But you said that was an endoscopic diagnosis. So surely it was the LA classification, or does the Leon, the modern Leon classification, I believe there's a revision of it, 2.0, but it relates mainly to acid exposure. So
the Leon classification is a document that was revised in, I think, August last year, and is what the international consensus on making the diagnosis of gastroesophageal reflux disease. It's a long document, but it gives, the main table basically says reflux is pathological when you've got endoscopic findings, and there's 3 of them: esophagitis, Barrett's, or a stricture. And if you don't have that, and you think you're dealing with a non-erosive reflux disease patient, then the diagnosis is made on a pH plus minus impedance study, and they give the specific parameters how we should be making that diagnosis on a pH study. So that's what Leon's about.
Yeah. And one thing that I think everybody is looking for is that obviously patients come back after Nissen fundoplications. It's not a perfect operation, and certainly 15 years ago there were lots and lots of them done. What's your approach to the patient who comes back with chest pain, perhaps heartburn, and very odd symptoms? What's your approach to that patient? Because I think that's the patient that surgeons should beware of, should beware of recurrent surgery, and should be referring to centres that are dealing with it and doing manometry. So what's your approach to the general surgeon for that type of patient?
Yeah, I think that's a very important question. And dysphagia after a Nissen is extremely common, up to 40% in some series. So it's a big problem, and it's a large part of the patients that I get referred from private are exactly this. So I think the approach is, number one, don't just think that the Nissen hasn't worked and that it's too loose and that you need to make things tighter. That's a very simplistic view of it. Remember that the symptoms of reflux are often not just from acid refluxing up into the esophagus. They might be due to poor drainage, which is more often the case. And to figure that out can be quite tricky. So I think you have to go through the motions. You should do a scope first and see what you're dealing with. And a barium swallow is very useful. The barium swallow is not there to confirm reflux or not. It's there to look at the anatomy of the OG junction and to look at the esophagus. We look at dilatation, drainage, and the timed barium swallow is very, very useful if it's done properly. And I think there should always be a low threshold, especially for a redo, to do manometry. There's a question on the chat here. Should you do a manometry? Is it an absolute prerequisite before an anti-reflux procedure? The exam answer is yes, I think. I think it should be done. And it should be an absolute prerequisite before a redo operation, 100%. One cannot say for sure, because there are many centers and certainly many places across Africa that don't have manometry. So we can't say it as an absolute. And if you don't have manometry and no access to it, then you can't be expected to deny these patients an operation, because in a well-selected patient, an anti-reflux operation is still a good operation to do. It's the best treatment for true gastroesophageal reflux that we have. There is nothing better, but you need to select your patient properly. And ideally, a manometry is what you need to do that. But I think a good barium swallow that you've looked at yourself with a scope is probably okay. But if you have manometry and things go wrong, I think this is where it comes in. If things go well, that's fine. Then there's not going to be a problem. But when things go wrong and you look back and you had the ability to do a manometry for the patient and you didn't do it, that's where it becomes a bit tricky. So I think that's my diplomatic answer to that question.
And there's one further question there regarding pediatrics and pediatric manometry. Do you do children? I know obviously there are units that are. And do you require special equipment for that? And what about the norms for children?
Yeah, excellent question. So we have had a few requests from Red Cross Hospital, which is our referral pediatric surgical hospital, especially for patients with achalasia. And we have done some, not very many. The main problem with pediatrics is that a manometry is an invasive procedure. You're putting a tube down, but you need a completely cooperative patient that's awake. You can't sedate them. You can't do this procedure under an anesthetic. So the patient needs to be awake. So in very small children, it's very, very tricky. We've done it before where we've anesthetized the child to put the scope, the tube down under the anesthetic. We wake them up and then we give them a few swallows while the mom is holding them, and then we see and we can get some idea of major pathological changes, but the subtleties are lost because it's very difficult to interpret. The other thing is we do have a slightly smaller tube here that's a little bit less accurate. It's an older water-perfused tube that I would use routinely for a child. The metrics are the same. Okay, they don't change as far as I know. I would use the same metrics to diagnose achalasia in a 10-year-old than that I would in an adult. So that's what we do. But pediatrics is a problem.
It's a particular problem because it is tricky to do. And we've often said, no, we've done it in a 2-year-old, we've done it in a 1-year-old. We use the same metrics. But the other thing that's very important in that case is to look at the pattern of the swallow. And often you can see quite clearly if it's achalasia or not in the little ones.
Thanks, Matt. I think we've really enjoyed, well, I've certainly enjoyed listening to you and the clarity of which you explain things. It's really quite good. Even a simple surgeon, hybrid physician like myself can understand it. So it's really refreshing. And I think for the audience, again, the take-home message for me is you may have good reasons to do a fundoplication still on the correct patients, but when it comes to revising these patients, you really should think twice about whether an operation would benefit them. And even if you don't have manometry, send them to a talking doctor like a gastroenterologist who will sit and really get into the symptoms, because I think it's really important. In that case you showed with the aperistalsis, the last thing you want to do is go there and redo the wrap. You're just going to end up with a complete disaster on your hands. And again, just to come back to what one of the old adages, you perhaps historically would remember Demister, on which the acid exposure is sort of based in the old days. But Demister used to talk about 3 things: the sphincter, the propulsiveness of the esophagus, i.e. its ability to clear itself, but also the fact that the stomach may not empty, and that may be the source of your problem. So, and again, do you have any gastric manometry available to you, or is it something that we should be thinking about, especially now that we've got all these rather obese patients and diabetics, where gastroparesis may be a real entity in some of the patients you're actually assessing for reflux disease?
Yeah, that's a good question. So there is an entity called gastroduodenal manometry. We don't do it. I've never done it. I'm not exactly sure how you do it. You meant to pass the catheter all the way down into the jejunum. That's how it's described. I'm not sure. It must be done endoscopically. I'm not sure. We don't do it. I don't know many centers that do it. Gastroparesis is often an important thing. I think in this day and age, the gold standard for diagnosing gastroparesis still remains a scintigraphy, a nuclear medicine study, and we do those every now and then, but you get an indication in your scope and your swallow. And certainly if you have a patient with an outflow issue, they will have reflux because it goes back up, and they can have horrendous esophagitis. It looks as stasis esophagitis is terrible. That doesn't mean that they have an Auger junction problem and need a Nissens. Quite the opposite. There might be something distal. So I absolutely agree with you. Yeah, I don't know any centers that do this gastric manometry, but it is described in the literature.
Yeah, because one of the other problems with the Nissen is that the vagus may have been injured during the primary procedure.
Yes.
And again, it may be very worthwhile, especially if there's food residue, to start thinking that you should be evaluating the stomach as well, if there's food residue after a Nissen that's starved. I don't know if there's any other questions. I think we have reached the appointed hour. I think it's for me to thank Matt for doing a great job, and to thank the team from iEcho for this. This will be recorded. You're welcome to access it through the Gastro Foundation. And I'm actually not sure what's up next week, but I'm sure it will be something of interest. It isn't about endoscopy. And I hope you've all enjoyed this. So thanks, Matt, and goodbye to everyone.
Thank you.